Good morning. I'm Red Schiller, interim chair of the Department of Family Medicine and Community Health at the Icahn School of Medicine and president for academic affairs at the Institute for Family Health. And I want to welcome you to what we think will be a delightful and informative grand rounds on HIV care by two physicians who work at the Institute. Um, One presenter is Dr. InSung Min, who is the HIV Medical Director for the Institute for Family Health, an assistant professor in the Department of Family Medicine and Community Health at Mount Sinai. She completed her family medicine residency at the Albert Einstein College of Medicine Montefiore Medical Center residency program and has been in the American Academy of HIV Medicine certified specialist since 2011. Since 2011, Dr. Min has been on the faculty at the Mount Sinai Downtown Residency in Urban Family Medicine, where she directs a 2-year track, HIV track, and develops residency curriculum for HIV treatment and prevention in the program. In addition to her expertise in HIV, she has experience in hepatitis B and C treatment, reproductive health, adolescent medicine, LGBTQ plus care. She's also attending at the Ally Forney LGBTQ Youth Crisis Center, where she delivers trauma-informed primary care and gender-affirming care to LGBT youth who are experiencing housing insecurity. Dr. Min is joined by Dr. Victoria No, who is a third-year family medicine resident at our Harlem residency. We are delightful to have her. She is one of our resident HIV resident providers in the track, part of the COMPASS program, and recently earned her HIV specialist certification this past January. We are delighted to have both of them present this morning. And just a housekeeping note, if you can, please fill out the evaluation form using a QR code. We need this for CME certification. And I'll leave it over to Dr. Min and Dr. No. Thank you.
Morning, everyone. Thank you for joining. Thanks, Red. We are here today just wanting to talk about the role of primary care, and we are hoping that we convey that it's at the center of HIV prevention and treatment, and that it's also primary care is used to bridge gaps in HIV care. Next slide, please. And I just want to review learning objectives and hoping by the end of this talk that learners will be able to describe some significant barriers within the HIV care continuum, aka cascade, also to understand how PrEP, PEP, and rapid start treatment in primary care setting can help address some barriers. Also to discuss HIV beyond viral suppression and how to optimize the health of patients living with HIV, and describe advances in treatment and prevention. And just on the right there is Peter Staley, and there's a quote, you can read it, but he did give a standing ovation talk because it was very inspirational at CROI, as it really helped shed some inspiration during this time of like lack of funding or decreased funding in HIV care. Next slide, please. So I wanted to start with the big picture and how we're doing in HIV care. And in response to the HIV epidemic, there were some ambitious targets set globally, nationally, and here in New York State. And these involve the end of the HIV epidemic programs and the USAID 95-95-95 program, where we're trying to get people to know their status, get them on treatment, and then ultimately get virally suppressed. Next slide, please. So there's been I think we want to start with the question, has there been progress towards ending the HIV epidemic? And the quick answer is yes. What has improved? According to the UNAID report, which comes out every so often, last one was 2025, the answer is yes. Globally, new infections have declined about 40% since since 2010, and 87% know their status, which is a really good thing, and 77% are on treatment. So these are clear signs of progress. Next slide, please. And while we've made meaningful progress, the reality is that we're still falling short of our targets, and we need to do better as a community. This slide highlights some key gaps that still remain. The EHE goals are in red, but millions of people essentially are still living with HIV, and many don't know it. And new infections remain far above the targets, and hundreds of thousands of people are still dying globally each year due to HIV and AIDS related deaths. So the bottom line is, yes, substantial progress has been made, but a lot of work remains. Next slide, please. And let's put these numbers into context. And talking about like treatment, mortality, and prevention, just starting with treatment, which is the blue bars, you can see that over time, there's been tremendous progress in HIV med uptake. Largely driven by the fact that integrase inhibitors, which are the fundamental med in one pill regimens that we're using now, they're really highly effective. They're really well tolerated and powerful. Globally, 30 million people are now on treatment, but that's only 75% who need to be. So roughly the other 25%, 9 million people are left without access. And of course, these numbers are probably going to be changing in this administrative time period, because the UNAID and the PEPFAR funding has been going down. And then when we look at mortality, which is the red bar, HIV-related deaths have declined significantly, which is great and encouraging, but still over 600,000 deaths per year, which is about like a death every minute. And most of these are preventable. We just have like amazing scientific tools and medicines to help with this. So it really is about access and prevention, which brings me to the last point, where we've seen steep reductions in HIV new infections in places, especially like sub-Sahara Africa. But there's still 1.3 million new infections globally, roughly 3 times our target. So a lot of work to be done there. And we'll also see how the progress overall, while there's progress overall, these gains are not evenly distributed, and they become clear when we look at who's acquiring new infections. So this is US data, and this is from 2022. I'll just mention like the collection of data has been changing over the past few years as well. But looking at this data, about 1.2 million people living with HIV in the US. Roughly a third is MSM, and less than a quarter heterosexual contact, which is a group that sometimes we don't think about when we're thinking about offering PrEP. And then 7% are among those who inject drug use, where that's a growing opportunity as well. We continue to see 32,000 new infections each year, and only a 22% decline. And our goal, the EHE targets were 71% decline by 2025 and 90 by 2030. So we've really missed that, despite having tremendous tools, and the set of tools are just ever growing. So next slide, please. So who's most affected? I was surprised to learn some of these numbers, but disparities persist by geography as well as through race, by race and ethnicity. Nearly half the infections occur in the South. Black African American individuals account for 38% of new diagnoses, and it's while they're not growing, those rates are stable. And in this scenario, stable is not a good thing. We really want those numbers to be decreasing. Black MSM and Black women there have been little improvement over time. And in this situation, like Latin Hispanic individuals make up about a third of new infections, and the Latin MSM group has the largest number of new diagnoses, which is actually increasing, doing the opposite of what we want, 20% in recent years. So next slide, please. And how are we doing in our own backyard in terms of new infections? Well, the purple is the EHE targets, and the blue line is new infections. And you can see that we are, over time, an early leader in EHE progress, with major declines pre-COVID, actually. That blue line you can see and the gray line is around COVID. And then progress seemed to slow after that, and new diagnoses have increased actually by 17%, and they're growing. So an opportunity for improvement. And how are we doing viral suppression rate? Well, let me just mention that this is like one of our number one goals in HIV care, because so much other goodness comes from having your virus suppressed and your HIV under control. And in terms of the US viral suppression, it's around 65%, which is actually lower than global rates at 73%. And New York State performs somewhat better at 81%. But I think a really interesting story is at the Ryan White clinics, who federally fund clinics with other programming that helps support people with HIV and who need prevention. And they serve over 500,000 people nationwide. We are actually a Ryan White clinic. Some of our clinics are getting funding. And that viral suppression rate is 90%, which is excellent, and way closer to those targets. And so it just shows, I think, an example of what's possible when the right support is given. Um, and not to be a downer, but that funding is going down. So, it's something that we just have to keep monitoring and see what's going on. But it's an example of how we can offer other support. Next slide, please. And if viral suppression is the goal, the care cascade continuum, we call this the cascade, helps us to keep track of how folks stay in contact with the health system, from diagnosis to suppression, and where we lose people along the way, highlighting where we might need to intervene. I will say, like at the diagnosis stage, like there are, you notice that number is 87%. So we are missing a whole group of people that don't come in contact with HIV testing and who don't know about their diagnosis. But at each step we lose people, and you see the end viral load. This is national data, so 65% for viral suppression. Next slide, please. And then for New York State, I guess like we should just kind of reflect, and I don't have answers, but like who are we screening universally? Who is being rapid tested effectively? Who are we not reaching is what I always kind of think about when Jay Musella and I talk through Compass and like programming and partnerships. We're just sort of thinking about like how do we reach more people in terms of diagnoses. And then linkage to care has improved, about 81% achieving suppression after diagnosis in New York State. So we're doing a pretty good job. But the bad news is, I guess there's always the good, the bad, and the ugly. And then the ugly news, I guess, is that the new infections, that rate is actually increasing. It was 7% in 2023, and more recently, it's still 5%. And those diagnoses are concentrated in certain areas such as Brooklyn, the Bronx, particularly among Black and Latino population. We also see regional differences, like in the Mid-Hudson region, which has historically lower linkage rates and higher suppression rates. So it's worth thinking about, could this be sort of reflecting fewer specialty providers? Maybe stigma is different. Maybe longer travel differences, all of which can delay care and impact continuity. Next slide, please. And I'm going to hand over to Victoria, who's going to talk about some of these things.
Thanks, Dr. Min. And so whenever we talk about the cascade or the care continuum, we think about where there are gaps, where patients are falling through the cracks in our system. And wherever there is disease, disease exacerbates disparity. And just like every other chronic condition that we see, we have the structural barriers, the social barriers, clinical barriers, and systemic barriers that we can take a moment to look at a little closer. In particular, with HIV care for structural barriers, we're looking at racism, transphobia, homophobia, sexism, and particularly the morality of disease, where whether or not you have a disease decides if you're a good or bad person, is a very prominent piece of our culture. In terms of clinical barriers, we have individual provider comfort and experience, as well as fragmented transitions of care when someone moves from one part of the healthcare system to another. We have social barriers, including interpersonal stigma, cultural insensitivity, and medical distrust. And we also have systemic barriers, such as the extremely complex network of medical care, including our specialists, with scheduling barriers like navigating English-only phone trees, limited clinic hours, the next new appointment being months away, as well as the typical transportation economic barriers that are not only due to cost, but also the fact that our patients have to work, and balancing their life as well as their healthcare. But whenever we talk about gaps, we also want to talk about the patients who do get to stay, who are retained in care. And 47% of patients diagnosed with HIV in the United States are retained in care, which is not a lot, but some. And in New York State, we do a little bit better with 55% to 66% of patients diagnosed with HIV being retained in care. So there's a lot of room to improve in retaining care, in retaining patients in HIV care. And the people who are the specialists of longitudinal relationships with our patients is us, primary care providers. The same skill set that we use to let new patients know that they're safe, supported, and empower them to return to care for any chronic conditions are the same skill sets that we use to let our patients living with HIV know that we are safe to come to and that we will support them through whatever they're going through. So these are skills that I'm sure most of us are already using to improve engagement, therefore increasing medication adherence and therefore increasing viral suppression. But just to touch on a few of them, we want to make sure we have welcoming, stigma-free environments starting from the front door, which means when patients walk in, they see decorations and people who reflect them and that they're addressed by how they want to be addressed. We have an expansive idea of what access to care looks like. So that is same-day HIV therapy initiation. We have walk-in clinic hours, evening appointments, weekend appointments, and also thinking about alternative spaces that we can provide care, so like street medicine and telehealth. We also want to make sure we are targeting patients when they are transitioning between adolescent to adult or prenatal to postpartum, because these are the places that patients often fall through the gaps, and we have an opportunity to catch them. In patients living with HIV, we also have higher rates of mental health and substance use conditions. And so these are also opportunities to make sure we catch patients where they are most vulnerable of falling through the cracks. Of course, this sounds like a lot, but we're not in this alone. IFH has this expansive team called our Compass team, and they are absolutely the best. They do so much for us and with us. They assist with needs like housing, transportation, medical and prescription insurances, other social services. They support patients with care navigators and community educators. They coordinate care around Rapid Start, ART, injectables, making appointments, including specialty appointments. They connect our patients to IFH and community-based support services like mental health. They identify and reach out to patients who have fallen through the gaps and are out of care. And they foster community engagement and partnerships in a way that allows IFH's HIV care to truly be part of the community. So I cannot emphasize enough how powerful it is that we have this team to collaborate with and work with to make sure our patients are getting the best care that they possibly can. And to summarize this first section with the state of HIV care, we are not on track to end the AIDS epidemic, but we know that the barriers are multifactorial in ways that primary care physicians are well poised to address. And with our particular values and mission, we know that we are well equipped to focus our engagement for prevention efforts and treatment efforts too, with populations with persistent disparities who would benefit from this focused kind of care. So moving on to our next section to talk specifically about how PCPs are part of the solution. This is my cat. Starting with intervention, we start with diagnosis. 6 out of 12 new diagnoses at IFH in 2025 did not have a rapid test. This means they found out that they had HIV at home alone. This is not to shame any of our providers, but only to emphasize that if we have a high enough suspicion to order an HIV lab draw, we should also be ordering a rapid in-house HIV test. Thinking about the patients who did find out that they were HIV positive at home by themselves, we had, and Dr. Min and I had an adolescent who, because of the stigma associated with the diagnosis, was lost to follow-up for over a year before they were brave enough to come back in and pursue care. We had several patients who came in for asymptomatic routine STI testing who ultimately found out they were HIV positive at home alone. And then we had a patient who goes through this very, very common scenario where they were coming in for a PrEP follow-up, but was taking their medications imperfectly, like many, many of us do. And sometimes we're not sure if that is an appropriate time to use a rapid test, but it is. And that patient also found out that they had HIV at home alone. So all this to say that this is a really good opportunity for us to catch our patients at the moment of diagnosis and being able to support them through a new diagnosis in real time if we use our rapid in-house HIV tests. How exactly we support patients with a new HIV diagnosis, big thanks to Annie Lukemeyer for these points, but when patients come to us with a new diagnosis, they are often preoccupied and in their own heads about what's going on, and we want to make sure that they know these things. And we're going to be able to say this to them over and over and over until it hits home. But we want them to know that with our new medications, they can expect to have tolerable medication options with minimal side effects. They can expect to not have any changes to how they look, that they can live a long, healthy life full of boring things like colonoscopies and teeth cleaning, that they can have as much sex or as little as they want without transmitting HIV, because undetectable is untransmissible, U equals U. That's very important to hit home for them. And that they're allowed to have children if they want without transmitting HIV. Like they can get pregnant, they can give vaginal births. And before, where we were saying breastfeeding was completely contraindicated, now we're moving toward talking about it more as a shared decision-making conversation. And so emphasizing that they can and will live and thrive even with an HIV diagnosis is so important. We also want to reinforce that treatment should be immediate, universal, and lifelong. So once we give this diagnosis, we wonder, are we supposed to start the medications or are we supposed to refer out? And the reality is locally with our Department of Health and globally through the WHO, the recommendation is to start medications as soon as possible. And that means you can do it. We have 3 rapid start regimens that we think about. The first one being Biktarvy, it's a 1-pill regimen. The second one being Tivicay plus Descovy or Truvada. You might be familiar with this already because it's the PEP regimen. And then there's a third regimen called Simtuza. And this regimen has a medication in it called a protease inhibitor and a booster that gives it more drug-drug interactions. So we tend to reserve this option for patients who have had exposure to Apretude or cabotegravir that makes it harder to give them the other rapid start options. So these are not things that you need to memorize. They're very easy to look up. This is only to familiarize ourselves with the medication options that are available. And not only can you start it, you should start it. We know that the longer it takes a patient to get antiretroviral therapy, the lower their CD4 count will get. And there is an abundance of research that shows that the lower your nadir CD4 count is, the worse your mortality and morbidity is, even after you get viral load suppression and even after you restore your CD4 count. There has been associations with less survival after non-communicable disease to the left, and then to the right, some journal article titles about sustained hypertension, functional connectivity, and memory. Even gut dysbiosis is affected by your nadir CD4 count. So that's one reason why we want to start ARTs as soon as possible. The other reason is there's this concept of viral reservoir, and this is the HIV virus that hides in parts of our bodies that treatment doesn't touch and our RNA tests cannot count. And so this is what causes the RNA of HIV viruses to rebound if someone were to stop treatment, and the reason why we cannot cure HIV. But we have found that people living with HIV who start ARTs earlier have a smaller viral reservoir than patients who are starting their medication therapy later on in their course. So 2 excellent reasons, I would say, to start antiretroviral therapies as soon as possible. The question then is, who is eligible for this? Can we just give it to everyone? And the eligibility criteria are pretty comprehensive. And so it's anyone who has a confirmed HIV diagnosis or pending confirmatory test. That means anyone who has had a rapid and they're still waiting for their blood draw to result, they are eligible. If they are an adult who has not used any ART before and are willing to use a 3-drug regimen, with the exception that even if they've been exposed to Apretude, they can still get rapid started using Simtuza, as long as they don't have tuberculosis or cryptococcal meningitis or CMV retinitis, if they don't have evidence of advanced HIV disease on exam, which means any unspecific symptoms you just don't feel good about, or if they don't have any renal or hepatic impairment on their medical history, they are eligible. You can rapid start patients who are pregnant, with or without active substance use, untreated mental health conditions, immigration issues, or unstable housing. Our concern that patients cannot follow up should not preclude us from starting them on medications as soon as possible. Ideally, we want them to follow up by phone in 24 to 48 hours and in person in 7 days. And this is another excellent part where Compass can help us out big time. So let's say you've decided, you've been convinced you're going to start rapid starting your patients. You're going to go to Google, you'll go to the New York State Department of Health, and you'll find this beautiful flow chart on how to rapid start. And I want to highlight that in multiple parts of this flow chart, our Compass team can really help us. So we have the counseling parts, we have the payment assistance, we have the parts where we physically are able to give them the pills or get them to the pharmacy to get the pills the same day of their diagnosis, and then setting up follow-up. All of that, our Compass team can help us with, which is amazing. And then our part as providers is this baseline lab testing, a bunch of orders. You order all the things on this list, but the one thing that I really want to highlight is the hepatitis B screening. The rapid start regimens inherently treat hepatitis B, and anyone with HIV, we would recommend treating their chronic hepatitis B infection. So that's one part. The other part is if someone were on the rapid start regimens and they wanted to convert to a two-drug regimen, such as Cabenuva, the injectable, anyone with chronic hepatitis B who was previously treated and then suddenly not treated, such as when they switch medications, are at risk of triggering a fulminant hepatitis episode, which can be very dangerous. And so in our population of patients living with HIV, it is imperative that we know whether or not they have a chronic hepatitis B infection. Just on the side, I want to mention that if you are Googling all this, you might come across this two-drug option called Dovato. It is a pill that is approved for initial treatment, but it is not for rapid start. You cannot start it on the same day because it only has two medications. You need to make sure you have resistance data to know that the patient is susceptible or the patient's HIV virus is susceptible to this medication. And we want to make sure that they do not have hepatitis B because this medication does not treat hepatitis B. At any point, if you're not completely sure, you can always get an expert involved. Genotype results, if they indicate a need for alternative regimens, if someone has extensive comorbidities, or you're just not sure, these are two warm lines that you can use. We have the New York State one on the left and then the national one on the right that you can call and ask questions. So now that we've treated our patient with HIV, are we allowed to keep the patient as part of our panel? And of course. HIV care is increasingly like primary care. I recently went to an infectious disease conference where a bunch of the presentations was teaching ID doctors how to do primary care and preventative medicine. So this is a perfect place for primary care providers to step in and really help bridge the gaps. There's a few questions about how HIV looks now compared to a few decades ago. And the reality is that it is a changing landscape. Our patients are getting older, healthier with viral suppression, and 60% of patients living with HIV are over 50 years old in New York State. And we expect that number to increase over time. The majority cause of deaths is no longer AIDS, which you see with the green bars slowly, steadily decreasing over time, but instead non-AIDS related cancer and cardiovascular disease, which you see are growing bands as we move through time. And the experts at screening for cancers and preventing and managing chronic conditions is us, primary care physicians. Some things that we do want to watch out for with long-term survivors is that they often experience early onset of aging-related conditions due to the HIV infection. And then also loneliness and isolation, as well as historical intersectional trauma as people have lived through the AIDS epidemic, and of course, all the historical trauma that has happened between then and now. So getting a little bit more into the nitty-gritty of our primary care and what is similar and what is different, the first tenet of primary care is cancer screening. To the left, you see things that we already do for all of our patients. On the right, you see what we do a little bit extra for our HIV patients. For cervical care, for cervical cancer screening, there is no longer an upper age we're going to screen through the end of their life. We also start doing anal cancer screenings, which is through something called an anal pap. You can look up the guidelines on that. And if you've never done one before, you've never heard of it, effectively, you just take a polyester swab, you hold it 5 centimeters from the tip, you insert it into the anus and sweep along the walls of the rectum to collect some cells, and you put it in the same thin prep container that we use for cervical paps. It's very easy. You can Google how to do it, and the UCSF guide is pretty straightforward. The other pillar is chronic conditions. So to the left, we see all the things that we do generally, what we already do for everyone. The only thing to think about is we pay more attention to drug-drug interactions as patients accumulate medications as they get older. And we also want to pay attention to the fact that diabetes is now diagnosed with fasting glucose, since anyone on antiretroviral therapies no longer has a reliable A1C correlating with their diabetes status. On the left, things that we do a little bit more for our HIV patient, or sorry, on the right, the things we do a little bit more for our HIV patients is in terms of cardiovascular disease, we're going to be offering statins, which I'll talk a little bit more about. For osteoporosis, we'll do DEXA scans for all postmenopausal women and men over 50 years old. We'll screen for renal diseases with Q6-month BMPs and urinalysis every year. And then we're paying close attention to HIV-associated neurocognitive disorders. So, between cancer screenings and chronic condition care, if you are taking care of your patients like you're taking care of literally everyone else, you are over halfway there. You are taking good care of them. You're doing most of it already. It's just a little bit extra that we want to think about. I specifically want to go a little bit deeper into cardiovascular disease because there have been new updates recently. You might have heard of the REPRIEVE trial. It was a trial that showed that patients with HIV who were taking moderate intensity statins had a 36% fewer rate of major adverse cardiovascular events over 5 years. And this was so significant that we changed our recommendations that instead of having a 10% ASCVD cutoff, we changed it to 5% for patients with HIV. But last month, AHA and their friends released the 2026 guidelines that recommends every single person with HIV starting at age 40 should be offered a statin, a moderate intensity statin. And this is because patients with HIV are at increased risk of cardiovascular disease independent of traditional risk factors due to a plethora of reasons that effectively accelerate atherosclerosis and increase their risk of thrombosis. So the bottom line there is every single patient with HIV who is 40 years old and older should be offered and recommended moderate intensity statin. And then to round out our pillars of primary care, let's talk about vaccines a little bit. On the left, you see the vaccines that are the same as the general population. I want to highlight that live vaccines, including the live monkeypox and the live flu vaccines, are contraindicated in our patients with HIV, and that we can only give the MMR and varicella vaccines if their CD4 count is over 200. On the right side is all the little extra stuff we do. We want to check the titers for MMR, varicella, hepatitis A, and hepatitis B, and make sure to vaccinate and check their titers again 1 to 2 months after, because patients with HIV may not launch as robust of an immune response to these vaccines. I also want to highlight for hepatitis B that our qualitative test for the surface antibody has a cutoff of 10, where for patients with HIV, we use actually a cutoff of 100 to say that they are immune. And so for these patients, you want to be getting the quantitative surface antibody test for hepatitis B. If they have not reached that 100, you want to revaccinate them with Hepcludex, which is typically a 2-dose series. But if you're checking after 1 dose and they have met their criteria or they've met that threshold, especially if they were already lone core positive, that's good enough. But if they haven't, you should complete that series. Other vaccines that we think about, meningococcal, we do every 5 years. With pneumonia, they are now qualifying for that one-time dose at any time in adulthood, so ideally at diagnosis. Zoster is also recommended for every adult starting at age 18, so at diagnosis. And then for RSV, you can decide with your patient if you feel like they are at high risk of serious RSV disease, in which case you would start that vaccination at 50 years old. So in summary, HIV care is primary care. PCPs can diagnose, treat, and care for our patients living with HIV in a welcoming, non-judgmental space, and we are so capable of doing it. We diagnose with a rapid in-house test, we treat with a rapid start protocol, and with longitudinal care, it's looking increasingly similar to primary care, especially when we're collaborating with our awesome Compass team. I'll pass it back to Dr. Min.
Thank you. So primary care, when we're talking about those care gaps, is part of the solution, but also advances in HIV treatment and prevention can also help with this, especially focus on long-acting options. We know from contraception care, I think of like that huge, list in the WRAP handout, but we have a lot of options. There's a lot of choices. We know that the long-acting ones are really effective, and so HIV care is moving in that direction as well. I've always thought that they should take more leads from the Women's Health Initiative, but ID docs and women's health, they don't really overlap that much. But my 2 cents. And then in terms of HIV treatment landscape, a couple of things to note. Like, you've seen big charts like this, very daunting. These are the drug charts full of pills and like a couple of injections. Um, and our treatment, sorry, next slide. Sorry, thanks. Our treatment options are truly remarkable. I think we have a lot of choice, which is great. But the current landscape, I would say the thing that creates success, as you heard me say earlier, is like the integrase inhibitors, which are really well tolerated, and they are often the backbones for a lot of our single pill regimens. And they are also the backbone for the new injectable. Um, and when I first started HIV care, the single pill regimen was like the superstar. I think then we went into a period where the integrase inhibitors were coming out. And I think now the newer superstars are new families of drugs, as well as the long acting options. Um, Many of these treat Hep B, just like Dr. No was saying, just as long as they have the tenofovir in them. Next slide, please. And we have learned also from contraception that choice is really good. One size doesn't fit all. We know that in medicine in general. The single tablets work really, really well for folks, and they really beat like the multiple tablets that people were getting during the older the in the 90s and the ones that have like a lot of side effects. But only if they're taken consistently. And for some patients, that's just not a reality for them, and we see that a lot. I forgot to mention earlier that IFH's viral suppression rate is about 85% as a whole. But when we deep dive into who is not suppressed, it's often those patients who these pills just aren't working for them. So in those cases, the long-acting injectables could be, or long-acting options could be life-changing. Next slide, please. So many of you already know that we use Cabenuva, which is one of the first long-acting options for HIV treatment. It was FDA approved in 2021. It has a combination of 2 drugs. So that was that trend of HIV care getting simpler with 2 drugs rather than 3-drug regimens. And in some cases, some pills have 4 drugs in them. But this is given 2 intramuscular injections every 1 or 2 months. And it's definitely non-inferior to oral ART and often have better results than the daily pills, as you might suspect. I mean, the downsides would be things like the injection site reactions, which don't tend to make people not want it, only in a minority of people, and little nodules in those injection sites. And then the other thing to consider would be when someone does fail this, and rarely there are failures with this regimen, you can have a 1 or 2 class resistance. Um, so this works really well, and it was FDA approved for suppressed patients. But what about those people who aren't suppressed, like the ones that we were talking about, that are having complicated lives and tough psychosocial situations? Next slide, please. So I'd say like another advancement in HIV treatment is that there is a little bit of a shift in terms of where research is going with the rollout of PrEP, oral PrEP from the beginning days. There was a lot of criticism about how it was not rolled out evenly, and we see that in the PrEP health disparity numbers. And so I think in terms of treatment, we've taken a note of that, and people are trying to push, even if the drug pharma companies are not necessarily looking at kind of the patients that give messier results, the adherence challenged folks. There's a push there. So Ward 86 and Latitude studies, those are 2 that did study folks with viral not suppressed viral load. And what they found was that they found good results enough to change the DHHS guidelines, where Cabenuva can now be an option for viremic patients, for those who are adherence challenged. And those suppression rates look like 80% suppression. So these are folks who just like, and we have seen them at IFH where like they come and they're just always virally unsuppressed. And so that is an option. under the right circumstances. And it does take some support, and we do have a lot of that support through our wonderful Compass team. So it's something to consider. Next slide, please. And in terms of other advancements in treatment, the treatment pipeline, there is the new medicine lenacapavir, which is special because it's actually in a new category of medicine. So folks who have resistance to a lot of the other categories, like some of our folks who got acquired HIV in the late 90s or the 80s, like some of those folks have been through a lot of different regimens and they aren't working for them anymore. So it's exciting to have new categories of mechanism of action. And so lenacapavir also is really exciting because it's a 6-month dosing. So that really helps for folks who just can't make it in or take meds or go to the pharmacy or like the million steps that you need to do in order to get your meds in your body every day. And it looks like a lot of the studies in the future will use this as a backbone just because it's so effective, and just trying to pair it up with other long-acting options. So other long-acting options are things like bNAbs or broadly neutralizing antibodies, also a different mechanism of action. This new class emerging is great. Not FDA approved yet, but a lot of studies, and it's being paired oftentimes with lenacapavir to see if that is a long-acting option for some of our folks. And then there are like weekly oral regimens, like lenacapavir comes in pill form, and then a new medicine called islatravir, another weekly pill. There are also things like implants being studied as well, but these are kind of closer to prime time. Next slide, please. So in sum, just talking about expanding options for HIV treatment, the integrases are sort of our darlings of the foundation of treatment because they work so well. Also, long-acting options like Cabenuva remove the need for daily adherence and provides choice. And expanded access to injectables to adherence challenge populations is sort of a trend in research. And I think that that will also help close gaps in the HIV cascade. And emerging options like Len and also new families, new classes may extend dosing even further. And I think what's really the most important thing with all of this new science is just who is getting access to that. So being able to like address costs, awareness, stigma, delivery systems, just where our focus is, just to make sure that the people who need it really are able to access these. Sorry, I'm getting over a cold. Next slide, please. So I think I have to cough for a second. Okay. Now we're going into HIV prevention and the changing access to prevention in general. And I want to talk about what we have in our toolbox and what's on the horizon and sort of how it changes our ability to fill in some of the gaps and what work we have to do. Next slide, please. So this is back to the UNAID AIDS data, the global data, where the blue bars show PrEP uptake, and then the red is for the 2025 targets for the EHE targets. And you can see across all different regions that we're falling short of the targets. And you see the biggest blue bar is the Southern Africa, which has made the most progress in PrEP goals. But in North America, which is all the way to the right, the gap remains pretty substantial. So we have a lot of work to do. Next slide, please. And how about New York State and PrEP uptake? You see by the blue line that we have improved, and we might even be closer to the target, the EETE target. The problem is that the PrEP gaps, it's a term that we use to refer to the difference between those who need PrEP versus those who are receiving it. And it is greatest among Black and Hispanic populations. So we really have to do a better job tailoring interventions so that they make sense and they are accessible for these populations that are most at risk. Next slide, please. So I just wanted to review who a PrEP candidate is, and some, the first part is risk factor based, so sexually active people with anal vaginal sex in the past 6 months and any of the following. So a partner with HIV, also remember to prevent vertical transmission, just folks who are trying to conceive. STIs in the last 12 months, so that's very broad. And I'm sure we've all seen that. And I just challenge you to think about, like, did you think of PrEP in that situation or not? If so, why not? Maybe consider it next time. And also inconsistent no condom use, which is also pretty common. So, and then I think this next category, injection, folks who inject drugs, and someone who shares equipment during substance use. I think there is also sexual use that is also happening there at times, sexual risk exposure. So that is an important group that we should try and remember to offer PrEP to as well. And I think the last group is the most all-encompassing, which is anyone who asks for PrEP. I think that we as primary care providers are on the front lines, and so we're in a really good position to offer it to those folks. And an important contraindication to PrEP to think about whenever you're thinking about PrEP is those who might need PEP. Anyone who's had exposure to HIV in the previous 72 hours. So those conversations, evaluation for PrEP and PEP kind of go hand in hand. Next slide, please. And then I just want to take a moment to mention how primary care is a critical entry point for HIV. Sorry, next slide. Yes, thank you. Primary care is a critical entry point for HIV prevention and care, and HIV care is a gateway to broader primary care. So they go hand in hand. And I just feel like when I'm at these conferences with ID docs who are like trying to figure out what to do after PEP, and are they going to see the patient again? I feel like we already do see those folks. And folks have probably seen cases where people just got PEP in the ED and then they're coming to you. And then once they're done, it's a good opportunity to put them on PrEP again or do harm reduction. And then also, if they're positive, do the beginning parts of HIV treatment, as Dr. No showed you how to rapid start. But I feel like it's also like really cool that all of this is also the carrot to link to regular primary care, which we're always trying to figure out like how to get people their care. Next slide, please. And I think just similar to the HIV treatment, it's similar to HIV treatment in terms of prevention. The growing toolbox of long-acting options is offering more choice. And I will just say this is kind of the next slide, please. This is just a table that looks confusing, and it's just laying out sort of various exposure risk, along with the different PrEP options that we have. And I'll tell you that we don't have data right now to support use of all options to work for all populations, but I do think that we're trying to get more data for that. So it can be confusing what to use for which PrEP to use for what exposure. But I'll say similar to Dr. No, like those two resources, the warm line resources, those are great options to, if you're ever wondering, you can try and figure out there. I will say the lay of the land is that we have two pills, Truvada and Descovy. Truvada is the only one that we can use for both daily PrEP, which is a pill every day, hard to do for some people. And those who are prescribing PrEP have probably seen a lot of patients who come back to you and they have not been taking their PrEP daily. So maybe episodic PrEP or on demand. We call it 211, and newly we're calling it 2111 for vaginal exposures. That is an option for folks who aren't having sex all the time, or maybe they're having it every once in a while. Descovy is an option, but it is not something we don't have the data to support on-demand use. And cabotegravir, aka Apretude, that could be an option for some folks who can't take a pill every day. And I would say it's also an option for folks with creatinine clearances that are with renal disease. Next slide, please. And there, in in June 2025, lenacapavir, this is like super exciting news internationally as well as in the US, where it got the standing ovation at the International AIDS Conference because the first studies showing that lenacapavir works 100% in cis women in those first studies was really exciting. That's what we're looking for in an intervention to prevent HIV. It's the every 6 months again, so that's great too. I think the the hard thing about this is that there are some, it's newly rolled out. We don't have it yet at IFH. Some of the other folks on this call on this grand rounds might have started already, and you might have seen that there are nodules that are happening in it, and this is often given in the stomach or the thigh. So we'll see how that pans out. It's a subcutaneous depot, lasts for 6 months, but that nodule issue can be a problem. Next slide, please. And I'll just tell you that this is just a slide to summarize that the research changes that are happening with Len after taking criticism and feedback about the disparities in other PrEP rollout. There's a lot of purpose studies. The purpose studies are the ones that are using Len as PrEP, and there's a lot of different populations who are being studied. So that will be good for us in terms of usage and knowing what the data is there. Next slide, please. Another thing to think about is just time to protection. And I'm not going to go through the details here, but the new guidelines from the New York State DOH kind of talk about this because different tissue have different time to protection. Next slide, please. And so these are some PrEP tips to offer you, like the updates that came out of the recent PrEP New York State guidelines. One is Descovy can now be used for vaginal sex, which it wasn't able to be used before. Now we have some data. Still shared decision making, not FDA approved yet. The second thing is for quicker time to protection that you can use a 2-pill booster at initiation, and that can help make it like in vaginal tissue, it's 21 days typically, but with 2 pills, it can be cut down to 7 days. And then we talked about the 2-1-1-1 rule. I know we're running out of time, so I'm not going to go in too much detail, but that for people with uteruses and for vaginal exposure, you can now do on demand, but you have to add an extra day at the end of a pill. And encourage same-day start, similar to rapid treatment. Shared decision-making is great for PrEP uptake as well as persistence. And long-acting options are now a choice. Next slide, please. These are some PrEP resources, the ones that Dr. No mentioned, along with the UW curriculum. And the UW curriculum has a whole section on PrEP tools, and it has a PrEP app that you can use. Next slide, please. The DOH has a pocket guide. It's really helpful, can show you like key choices in PrEP regimen, key factors and choices of PrEP regimen. So if things get too confusing, that's an option. And these are just some future possibilities that are being studied along with the injection. They're trying to, we're looking at extension of cabotegravir implants and injections. And in summary, I'd say like, next slide, please. Daily PrEP is very effective, but not for everyone. Long-acting options are better for adherence. There are a lot of long-acting emerging options that we have our eyes on. And then, of course, like who has access to all of this? And, I was going to go into DoxyPEP, but we're running out of time. So I'm going to end it to next slide down to slide 61. Yeah, this slide just shows you how the New York Department of Health has everything kind of outlined, very organized and beautifully, so you can use that. And then the last slide, please. I just wanted to thank everyone for their time. And I just want to remind you, I want to end with the thoughts of how you can think about how primary care, I hope we've convinced you that primary care can be really wonderful in terms of filling in some of those gaps that no one else has access to, like the ID docs don't have access to that in terms of like seeing the patient with such frequency. So thank you. And here, next slide, please. Here, we're just going to leave you with the guidelines and some curriculum. We're just wondering if there are any questions or comments or thoughts. Sorry, we didn't leave them.
Sure. Let me just interrupt to thank you guys. This is pretty amazing. I mean, the amount of data and information is significant. And I think, in particular, your connection to primary care and the fact that, I mean, kind of like diabetes, that, there's just not enough capacity for ID specialists to take care of these patients. So the model of, providing this as part of primary care is crucial to achieve those larger public health goals. So thanks a lot.
And we do have a couple questions here for you. And I'll read them out now in order. So this is, I think, in relation to the Institute for Family Health offices, and you may not be able to address this, but I'll read it out. Do all of our offices have the correct swab for anal paps? This provider hasn't seen them and has been using endocervical brushes. Yeah, and I know that might not, especially if we're talking about upstate, but that might be something for our team to look into.
Yeah.
Yeah, I've noted it down to look into it. I do not know the answer to that. It sounds like no, and that's what you're kind of telling me through your question. So we can definitely look into that.
But for the gonorrhea chlamydia swab, the Aptima cleaning swab is also made of polyester and might be more comfortable than an endocervical brush. Can you confirm that, Dr. Min?
This has come up before, and I'm not sure if it's something that we can use for the anal paps. And the anal paps are so precious to me because no one wants us in their bottom, and it's just really once you get it, you really want to make it count. And so I do want to get the right swabs to you guys.
We'll check on that.
Yeah.
Yeah, thank you for bringing that up. Another question, and you may have addressed this after this question came in, but what is the data showing around PrEP for people with vaginas and uteruses? There were discrepancies in efficacy before.
Yeah, there is that idea that the tissue is different. The rectal tissue and the vaginal tissue is different. And when they check levels and for protection, the vaginal tissue, it seems like with oral PrEP like Truvada, it takes 21 days to get to that efficacy for protection. And I think we don't have that problem with cabotegravir. There's more of an even distribution there. What we're saying for most forms of PrEP is that especially with the 2-pill starter, that 2-pill boost on day one, that about 7 days is time to protection. But in terms of like the absolute data, like I don't have that at my fingertips. This is just sort of what I've read and what I've heard in terms of like the updates. And the New York State Department of Health guidelines, the new update that came out like October, November, might have some of the references to the nitty-gritty data.
All right. Thank you. And then our last question here, and again, this might be some feedback for the Institute. We've had so many great shout outs to our Compass team, and I see Jay in the chat thanking you for that. And here's the question. We speak about higher levels of HIV in Latin, Black, and Bronx patients generally in communities. Should all of our clinics in the Bronx not have Compass representatives then? What would benefits and detriments be to having Compass available at all of our clinical sites in the Bronx?
This is an interesting question, and it's definitely something that we've worked on before. All of them, I'm not sure exactly. So we do have representation in urban, but I think in terms of Walton, where we have a considerable number of patients in Stevenson, we have more individualized, like Compass Light is what we call it. So individualized help. And so I think other folks do have access to Compass in the Bronx, but I think you're right. Like, I think it's partly driven by like HIV specialists because we don't have specialists in some of those other clinics, but it is something that we're working on and changing. And so we're just having a little bit, we do see the need for more Compass representation in places where our patients are at. Totally agreed with that statement.
Although Jay just noted that Compass services are available.
Yeah,
So,
they're available.
but
They're
they may not be on
available,
site. They may
but
not be
they're
on
not
site.
presently physical.
Yeah, no,
Because,
that's a challenge with funding. So
yeah, which
uh,
is just getting more narrow, which is
I just have
unfortunate.
a sort of a brief question about what's the recommendation of the role that specialists play, HIV specialists play in a primary care setting. And, I understand, I think that isn't it a requirement that patients see an HIV specialist twice a year? And what's our, you know,
Policy.
yeah, exactly.
That is at IFH, that is the policy. It's not exact to twice a year, but it's under certain circumstances for sure. Like folks are sick, kind of the things that Dr. No went over. Folks are sick.
Mhm.
If folks have comorbidities, like a lot of comorbidities, they have viral loads that aren't suppressed and they need to change meds. That certainly, I think, could use a specialist's skills. And I think the policy in general, in terms of reimbursement, is that it does need to be, we get higher reimbursement when a specialist is seeing patients. And then I think as Dr. No kind of went over, and there's a lot of things that Dr. No left out because we're trying to make this palatable for primary care. There are things to think about. And so linking back to a specialist at least once or twice a year, depending on
Mhm.
um, how able that is. It's not always possible to do that. But also just at IFH, we also encourage like consulting a specialist and just going through the chart together, that sort of thing.
Great. Well, we're over time. I just want to thank you both for an exhaustive and but well-organized approach to HIV care in a primary care setting. And we're especially delighted to have a resident. So, so thank you, Dr. No, and keep up the good work. Thanks, InSung.
Thanks,
Feel
everyone.
better.
Thank you.
Have a good weekend.